Joseph Carandel, who's the Lamb Clinic Director at the Cleveland Clinic. And he is going to be discussing symptoms that we should be concerned about. And it'll be a short presentation, and again, we'll open it up for question and answer.
Thank you so much. All right, thanks for this invitation to spend some time with you to talk about symptoms of concern in LAM. Now, when Dr. McCormick asked me to give this talk, I started scratching my head because it's truly a difficult topic to talk about, because he said, Joe, talk about symptoms I should be concerned in LAM. And I told Frank, I said, Frank, here's the issue. As a physician, there are symptoms I am concerned about, but as patients, there are symptoms they are concerned about that as physicians we're like, that's not that big of a deal. So what we'll do is, I'm going to keep this as interactive as possible. I'm going to talk about symptoms that we as physicians look at as concern for us to your health. But we're also going to talk about symptoms that you guys think are important, that sometimes a lot of your doctors are like, no, that's not a big deal, because sometimes it's just fatigue, sometimes it's just a disabling cough that bothers you, things like that, that most physicians may say like, no, it's okay to work with. So we'll talk more of that in an interactive basis, but we'll talk about some of the symptoms that come as red flags to us when we are involved in taking care of patients with this disease. So we know LAM, I know all of you know that LAM is a disease that is characterized by these cysts within the lung. We're still trying to figure out where these LAM cells come from. All that we know is that these LAM cells tend to enter the lungs, and once they enter the lungs, they don't know what to do over there, and they start to cause this destruction of the lung, and as the lungs get destroyed, the lungs get replaced by these cysts, these little holes in the lungs. And there's a great variability to it. Some people are very mild, just a few cysts scattered here and there, and some patients have a lot of lung that's taken over by these cysts. But by and far, as a consequence of these LAM cells going into the lungs and causing these cysts that slowly can replace the lung, patients tend to get symptoms of respiratory impairment. Now, unfortunately with the lungs in general are divided into three major categories. We have the airways or the breathing pipes, which by far the commonest disease we talk about is emphysema or COPD or asthma. Then you have the lung tissue in and of itself, which is what's involved in exchanging the oxygen into the blood. And then the third tissue, or the prominent tissue in the lung, are the blood vessels. Now, disease of any of these three can cause just the most common symptom that we see in the lung, that is shortness of breath, or what we call dyspnea. And in LAM, we know that because over time, sometimes the lung can get replaced by more and more of these cysts or these destructive spaces in the lungs, the shortness of breath tends to become more and more progressive. The other issue that's characterized in this disease, unlike, say, other respiratory diseases, is that because these cysts are air-filled spaces, like you can see on the slide over there, these air-filled spaces, some of them are just right next to the lining of the lung. These can sometimes pop or get a tear in the wall, and you get the so-called pneumothorax, or a lung collapse that we call. And finally, we know that in LAM, this tends to be a disease that affects through the lymph vessels. So the lymph vessels are primarily vessels that are similar to your blood vessels, but they take away extra fluid. So what do I mean by takes away these extra fluid? Is if you ever injure yourself, you get a little bit of swelling, correct? Now, in that area of swelling, over time, that swelling goes down. And the reason why the swelling goes down is that because of these lymph vessels, they suck out all that swelling fluid that's accumulated over there and goes away. Now in LAM, we have a lot of these lymph channels within the lungs. And in LAM, we believe that these cells can affect these channels specifically. And as a consequence, we get leakage of fluid, even without injury, into the space between the lung and the chest wall. So these are the three key features of this disease. And since we know that these LAM cells come into the lung, over time can take away the lung space and cause these cysts, patients tend to lose lung function. Now, what do I mean by patients lose lung function? We all lose function. There's a term that we use in pulmonary medicine called senile emphysema, or just emphysema of aging, meaning as we age, just because of the wear and tear of motion, you got to remember the lungs are always in motion. It's not like, say, certain muscles that move only when they're supposed to move. The lungs are always moving in and out, in and out, in and out. And over time, we all lose some degree of lung function. And the lung function you lose on an average is around 15 to 30 ml lung function we lose a year. Now, on an average we have, when I say lung function, when I say ml, you're like, what is normal? So normal, we can take in 4 to 5 liters of air per minute. And with this loss of 14, 15, 30 ml a year, the amount of air we can suck in as our lifespan goes on becomes progressively less. But it's minuscule. It's not a lot, and it translates in a span of decades. However, in LAM, because of this disease affecting the lungs, in patients we've seen that the rate of loss, this natural loss of lung function, is accelerated. So instead of you losing 30 ml per year of function, which is normal, in LAM patients we've seen the loss of lung function tends to be at the rate of, say, 60 to 120 ml per year. So you lose lung function at a faster rate. So what does all this translate into? So the most common symptom patients with LAM complain of is shortness of breath, or the symptom of dyspnea. And dyspnea can occur either because lung function is reduced, either because there is collapse of the lung, or because one of these lymph vessels have got a tear and there's leakage of fluid into the space between the lungs and the chest wall, or rarely, very, very rarely, because of development of high blood pressure within the lungs because of low oxygen levels. Now, as I described, all these four, from a biological perspective, have very different mechanisms, yet when the patient perceives it, it is just with a single symptom of progressive shortness of breath. I am getting more and more short of breath. And here's the frustrating thing for us as physicians. We are made with way too much lung. It is a good thing, and it can be, for us as physicians, it can be it's not that great of a thing. And what do I mean by that? Is that we are made, let's say, with 100, 120% of lung function. Let's say 100% is normal lung function. That's when you do your breathing test. I'm sure every LAM patient has done a PFT, and you get this number, oh, your lung is functioning, let's say 90, 100%. But what you got to remember is that what does this translate in real life? Even a study was done on professional bicyclists, so Lance Armstrong and these sort of guys. They put them on a bike, made them train, and even at maximum exercise capacity, they're pushing up as hard as they can. The amount of lungs that were tapped into were only 70%. So 30% of lung function is basically never ever tapped tapped into. It's just there. We've got way too much lung, which is a good thing in the sense that, you know, the lungs can be used. Even though you lose lung function as you age, still you have enough lung to do your activities without limiting you. What is a bad thing for us as physicians is that it becomes very, very hard to pick up disease at an early stage. That's why many of you may know colleagues that smoke cigarettes, and you're like, oh, I smoked cigarettes since I was 20 years old. I'm now 50 or 60, and only now I'm getting short of breath. Why? They've been damaging their lungs for years and years and years, but just because they had so much lung, nothing really happened until a significant portion of lung is lost, and then you get symptoms. And that's why it becomes hard for us to pick up disease at an early stage when intervening can maintain. You get what I'm saying? All right, so that's the thing with LAM, and so shortness of breath is a common symptom that we see, and this shortness of breath can be progressive. So we've seen that from the British, what they've shown is that in patients who have LAM, by 10 years, almost 50% of patients notice shortness of breath on walking a flat surface. So in other words, it means that by 50% of patients notice shortness of breath when they walk 1 or 2 blocks. Just regular walking, they get short of breath. And we've seen that a smaller percentage, this is around 20% of patients, would need oxygen by 10 years or so just because of progressive loss of lung function. Now, be careful, when I showed this slide or this data from Johnson, basically what they're talking about is in patients who have progressive decline in lung function because of these cysts or these air spaces replacing lung. However, it's important to remember LAM patients can get acutely, meaning within a couple of minutes, within an hour, the sensation of I can't breathe, something's going wrong as well. Okay? All right, so what are the other symptoms that can be seen in LAM patients? Cough. Cough is very, very common in LAM patients. Cough, in fact, can be quite disabling. Why do LAM patients get cough? Now, we know that when we do breathing tests on patients with LAM, for many years, LAM has been misdiagnosed or incorrectly diagnosed as saying you have asthma, you have emphysema. Why? Because your breathing tests show up in a pattern of asthma or emphysema. So remember I said the lung has 3 cardinal components: the breathing pipes, the lung tissue, and the blood vessels. And even though LAM is a disease of the lung tissue, these cysts, these LAM cells, tend to preferentially go close to the breathing pipes, close to the airways. And so that's why patients with LAM tend to get a lot of airway-based symptoms, or asthma or COPD-like symptoms of a lot of coughing. Somebody's wearing strong perfume in the room and you're like, oh, I got a cough. Somebody's smoking, you cough. For those of us that live up here in the north, a cold day, I think I'd rather stay inside because I know I'm going to start coughing or my chest is going to get tight. And for a lot of physicians that do not know LAM or don't understand LAM, you say, oh, you just have asthma, you just have COPD, take some inhalers, they will help. And don't get me wrong, these inhalers in some patients do help, but before we know the disease, just by taking the inhaler in and of itself is not helping you because we're not making the right diagnosis here. Other symptoms, chest pain, and we'll talk a little bit more about this. This is a symptom of concern when a LAM patient says, Doc, I got a lot of chest pain and I can't breathe. We get concerned, and I want to educate you or empower you to say that this is something, if it pops up, you should be like, wait a minute, I should pay a little bit more attention to it. other important symptoms, chyloptysis, hemoptysis. What on earth is that? So remember I said that these lymph vessels can have a tear and leak. Sometimes these lymph vessels can leak even into the bleeding pipes, and patients can cough up this milky white fluid, and that's what we call chyloptysis. It's very scant. It's almost like frothy white stuff. What is this that I'm coughing? And occasionally, when the cough can be pretty significant, you can also have a little bit of blood tinge in this in the sputum. And finally, the whole concept of chest tightness, chest fullness, and this can be quite a difficult symptom for patients. And it's not talked about a lot among us physicians. And the reason why patients get a lot of chest tightness, fullness, and one of the characteristic features that LAM patients talk about their chest tightness and fullness is that I have a lot of fullness here at the bottoms. You know, it's like almost like where my brow, not my brow lining, but where the brow lining is. But it's very tight around over there, or fullness right here in the middle of the chest. And to try and make you understand why you have that is to give the whole parallel of asthma. Asthma patients or emphysema patients often complain of a very similar symptom. And the reason why this happens is that remember I said these lungs have a tendency to go next to the breathing pipes, the airways. Remember I said that patients can have breathing tests that look like asthma. And so as a consequence, what happens is that you take in air when you have something bothering the breathing pipes. The breathing pipes are very good in allowing air to enter the lungs, but they aren't very good in allowing air to leave the lungs. So what happens is that, similar to asthma and emphysema, what happens is that you inhale, your lungs fill up, but you try to exhale, you don't empty completely. So over time, your lungs become these big, big bags, and the pain, the discomfort that patients feel over here is basically a stretch of the diaphragms, a stretch of the ribs and the intercostals that happen over here, because now you've got these big lungs that are pushing on the diaphragm down and not allowing you to come back all the way up to breathe normally. Do patients understand this? I mean, stop me if you want, raise your hand if you want, just interrupt me and speak if you want. I mean, I'd like this to be as interactive as possible, because at the end of the day, this is for you to learn, for you to get educated and get empowered. It's not for me to have a dry mouth.
You're the first LAM doctor that I've heard say that pain and where that pain is from. I have asked numerous times because it happens every day, all the time.
Correct, and it's very variable. It's some days are worse than others. Some days you just wake up, or even you wake up in the morning, you're fine, and as the day goes by, some days you're like, wow, it's like this terrible pain, especially in the sides over here. And it's a symptom that you feel. It's mainly because your lungs are just stretched so big, you know, and your lungs don't empty out. It's like a muscle strain, what you gotta remember. It's like you work that muscle so hard, and that's why many of you may even notice, I wanna just massage. If I can get a deep rubbing, it'll get better. And what it is, it's just a pull of the diaphragm. So what you gotta remember is that your diaphragms are basically meant to be dome-shaped like this. But when your lungs fill up, and remember your diaphragm is like a muscle. It's like the bicep, it's like your leg muscle. It's just a muscle, it's just a skeletal muscle. It thinks the same way any other muscle thinks. Now what happens is that for a muscle to work, the muscle should be in a relaxed position, which for the diaphragm is a dome. When it contracts, it goes down and becomes flat. So what happens when the lungs are filled up, so like I said, what happens, your lungs fill up with air, they fill up, but when they don't empty, guess what happens to the diaphragm? That diaphragm cannot come back up to its relaxed position. It remains in that tight position. So it's like you keeping, let's say, I'm asking you, hold a 5-pound weight and just keep your arm contracted. After you're like, ouch, that muscle hurts. I want it to relax. Same concept over here. And that's why it's variable during the day. It's like some days, you know, the lungs can exhale all that air. Some days, that's why it's so variable. It sounds like these asthma sort of patients. And that's why you get this pain, which can be quite troublesome for a lot of patients. All right, so let's talk about. Oh, I'm sorry.
So, what's the best thing to do?
I was hoping to get away from that, but no. No, so usually, if an inhaler works, use that. But for most of our LAM patients, inhalers just don't do anything. What the inhalers do is they just try to open up the breathing pipes as much as it can. So you exhale even 20, 30 ml of air, it just relaxes the diaphragm. What usually has helped most of our patients than anything else has been this pursed lip that you keep that lips pursed down and then you try to slowly let the air out, because the reason why the airways don't allow this air to leave the lungs is simply because with normal breathing, most of the air just leaves the lungs really, really quickly. But here what happens is when you exhale, the airways collapse on you, they narrow on you, and they don't allow all that air to come out. But the brain is like, okay, I gotta take the next breath, because this is the time you have to breathe out. And so what usually helps is when this happens, you just do that pursed lip breathing to just slowly force, because by pursing your lips, what you're doing is you're keeping pressure in the throat that is transmitted down into the pipes to leave those little airways stented open to allow the air to slowly come out. And that's something that tends to help more than anything else, because you can sometimes get stuck in a dangerous, vicious cycle, because don't get me wrong, morphine and these sort of drugs help a lot, but it can become a vicious cycle.
Is that the same thing? Like, I get these little sharp flinches.
Sharp flinches, that's right. It goes away, it comes, and some days it lasts longer. Some days it's a little sharp jab over there and it goes away.
Is that the same principle?
That is the same principle, yeah, especially is down here, correct. Right, and that's quite of a nuisance to patients.
Is it common to get the
Chyloptysis?
After bronchitis?
Very good. So, absolutely. So, bronchitis is inflammation of the breathing pipes. And whenever you get inflammation of the breathing pipes or inflammation anywhere, let's say you got an infection of the finger or something like that, the whole area becomes red. And the reason why it's red is because the blood vessels become leaky and prominent to allow your immune cells to go in over there and fight it. Now in LAM, you've already got these leaky lymphatics that are there, and so now on top of it, you put an infection that makes the whole place even more leaky. And you're going to cough up a little bit of that, but you may have some blood in your sputum. So that's another thing. And bronchitis is something that can be seen at a higher rates in our LAM patients than, say, people who don't have LAM.
I wanted to ask another question about pain, because I think what you were talking about and what a lot of us get are these pains like all over. Like I'll get them in the front, I'll get them in the back, I'll get them in the side, and sometimes they're sharp, and sometimes they're achy, and sometimes they're quick, and sometimes they stay. And I've heard of some patients say that, oh, my cysts are popping. And
that's what I was going to talk about with pneumothorax.
Well, and my thoracic surgeon said that maybe they're blebs that are rubbing on the pleura and that's causing some pain. So is it just a lot of different things that are happening?
So there are multiple things. So I was going to touch base on with pneumothorax, I was going to talk about that. But there are many causes to this pain. One of them is the whole diaphragm issue. The second one is the pneumothorax, which we talk about. The third thing is most LAM patients have undergone some sort of intervention into their chest space because of a collapsed lung, or they've had surgery done, like a pleurodesis done. Now what you got to remember is that the chest wall is one of the most innervated structures in the body. There are a lot of nerves that run in and around the chest wall. And we've seen, despite surgery, despite a tube put in, when a nerve gets injured over here, you can get that pain from that nerve injury. And the final last thing, what we've seen in patients with LAM is this so-called breastbone pain or chest wall pain. And what that is that if this is your breastbone, these are your ribs. The way the ribs run is you have your breastbone in the front, you've got your spine at the back, and your ribs run attaching from the spine to the breastbone. The way we were made is that the chest cavity is primarily a protective cavity for us. It's not like your bones of your arms or like that are meant to move and help you do a lot of stuff. It's just protect these vital organs. That's the main purpose of the breast, these bones. And so these joints, the joints between your ribs and your breastbone, aren't designed like, say, your shoulder joint to be lubricated for a lot of motion. You understand what I say? And so here's what happens in patients who have any respiratory disease, including LAM, is that when you're normally when all of us breathe, breathing is primarily a diaphragm function. And what do I mean by that is 80% of the work done in making a patient breathe is by the diaphragm moving up and down. So if you were to watch a little child on a summer day running around breathing, the main thing you see is that belly go up and down, up and down. It's the belly that moves. It's because the diaphragm is going down, pushing the belly contents out, and it's the diaphragm that does all the work. However, when you've got disease that is either impairing diaphragm function or exaggerating diaphragm function, guess what happens? The body says, this person's got to survive. I've got to send in recruitment. I've got to support this person to breathe. So who assists? The chest wall. And what I mean by that is your intercostal muscles, your pectoral muscles, your neck muscles, your shoulders, your back, all these muscles start to assist in helping you breathe. And so when these start to pull the ribs, so what we call thoracic breathing. So we see sometimes in patients with respiratory diseases, including LAM, it's like instead of this whole belly breathing, the chest is doing most of the work. And what happens when the chest starts to do all the work is that the rib breastbone interaction was just supposed to stay stable, now starts to move. And this movement over here causes the body to say, wait a minute, I'm not lubricated to move over here. And that causes a little bit of inflammation, especially patients with complain of this, just a line around over here where the breastbone is. Boy, it's so sore to touch. And you may complain of that as well, and you want to put a cold compress or a heat pack or take some Aleve or something to relieve this. And that's the other sort of pain that patients feel as well. And even with the whole shortness of breath, sometimes patients often complain to me, you know, I could walk from here to the end of that door room fine, but you make me carry some groceries and I walk. And I'm like, I'm winded. And that's the whole same concept. The reason why you are winded when you do any sort of upper extremity activity and you walk is because when your arms are left alone, your chest wall, your neck, your back, they can all support your diaphragm to help you breathe. So breathing is the main thing those muscles are working towards. But now you start lifting something, guess what? All that work that used to help the lungs is now being directed to helping lift the grocery or your laundry or something like that. And work is taken away from your diaphragms. And so now you're just breathing with diaphragms, you're like, oh my gosh, I am really short of breath. So it's not that you're crazy or you're imagining things. There is a medical explanation for what you feel. All right, if I can find that. All right, so this is pneumothorax. So this is a symptom we tend to be concerned about. This is the lung collapsing because, like I said, you get these cysts that can be next to the lining of the lung, and sometimes there can be a rent in it, or they can pop, and your lung can collapse. Now, the symptom associated with pneumothorax is pretty acute. We spoke about patients who have shortness of breath can be gradual, but patients with LAM can get this acute shortness of breath with chest pain. So if you notice boy, I can't breathe, and you're having a lot of chest pain, that is something of significant concern. Call your physician or go to the emergency room because this is serious business. Chest pain occurs, it's sudden onset, it's sharp, and usually there's some chest tightness. The lung collapses because now there's air getting into this space and it's pushing down on the lung. You can get shortness of breath, you can notice your heart is racing, your breathing becomes more rapid, and you could be coughing. Now, why is pneumothorax of significance? We know that, as you can see in this chest x-ray over here, this whole lung is collapsed. And this is basically the little lung that's collapsed. This is all air in here. This is the normal lung. And the other thing I want you to pay attention to, this is a patient with LAM. Look at those diaphragms, how almost flat-lined they are. Like I was talking about the diaphragm pain that patients get. Most of the time, the diaphragm should be a nice big dome up here. But this is nice and flat. All right. So why is pneumothorax such a big deal in LAM patients? Is that almost 70% of LAM patients get pneumothorax. And among all lung diseases that we see as respiratory physicians, the highest rate of recurrence occurs in LAM. And what do I mean by recurrence? Is that pneumothorax occurs because somebody's had a gunshot to their chest, or because they're tall and, I mean, they smoke some cocaine or some, it doesn't have to be parts of cocaine. but patients can get a collapse of their lungs. But in those kind of patients, it doesn't come back. The problem with LAM is that once you get a lung collapse, there's a huge risk of these coming back over and over again. And when we look at patients who've had pneumothorax in LAM, we've seen that on an average, now this is not every single LAM patient this is going to happen, have around 3 to 4 episodes of pneumothorax throughout their life. They need some sort of intervention at least 5 times, and the estimated cost is around $75,000. So it's a big deal for LAM patients when they get this pneumothorax. And what is generally done for pneumothorax is one of two things. Either a tube is put into the space where the air is collected, and you just let the air leak out and let the lung heal on its own. Or the second thing is, well, even though I'm putting the tube in there and letting it heal on its own, as a physician we make the decision, let's just shut the space off. So one of two ways: we passively let the lungs heal and let the rent seal off, or the other way is we actively intervene and try to do something to seal this hole off. So which is better for a patient with LAM? We know that from studies that have been done in patients with LAM, if your doctor just lets a tube and say, okay, with time, this is gonna go away, we usually tend to say, no, even with the first episode, an active intervention where we shut off that space is a much better approach for LAM patients because of the risk of the lung collapsing again. And how can we close the space off? And I know there's another talk that's going to go on over pneumothorax and pleurodesis and things like that. But there are two ways. One is chemical, the other one is surgical. In chemical, basically, medicines are put into the pleural space, and medicines include things as toxic as bleomycin to as mild as baby powder is put into the pleural space, and it just irritates that space and it just shuts that space off. And the surgical way of doing it is quite similar. What it is that you take something like a Brillo pad, which is it's just sterilized and a lot more expensive because it's medical, and you just scrape your lungs and it shuts it off. Go ahead.
I had a left lung collapse in 2007, and then my right one did in 2009. And this was before I was diagnosed with LAM. And the thoracic surgeon, they went in and stapled my right lung to my chest wall with titanium staples and lined it with the pericardium of the bovine. What would that be called? That's not chlorodesis, is it?
No, that's titanium pericardium. I don't know what. I have no idea what they meant to me. But that's not chlorodesis. Yeah, chlorodesis is a lot more simpler. I mean, as you can see, for chlorodesis, very simple. It's, as you can see, we're simple-minded physicians. We use baby powder and Brillo pads to obliterate the space out. You don't need anything else. All right, so what is this? Why do we say obliterate that space is better off than just putting a tube? Because if you just had a tube in there, the rent would close. Don't get me wrong. You put the tube in there, most patients, day 7 comes, that air leak is going to be gone. The surgeon say, oh good, the air leak's gone, lungs up, go home. But guess what? Over 2/3 of patients, that lung is going to collapse again. But if we were to close that space up, either by chemical or by surgery, the likelihood of it coming back is much lower. However, we know that if we did this, say, for a young man that did cocaine or something that got shot, and we scraped that space and closed it up, this rate would be like 0 or a single-digit number. And just as the lady over there had mentioned, the reason why we see that it is not as successful has been that these LAM cysts that are on the surface of the lungs tend to make the lung surface very irregular. So usually the lung surface is nice and smooth, and when you inflate the lung, it sticks up against the chest wall. But when it's irregular, you get these crevices and cracks over there that the two surfaces don't meet for them to scar off and stay close together. So that's the whole reason why it's not as successful or as best. The other thing is many thoracic surgeons still think that closing off that space, pleurodesis, and that's in fact the #1 reason why many thoracic surgeons tend not to pleurodesis patients, that, well, if I pleurodesis you, when it comes time for you to maybe need a lung transplant, you may not get a lung transplant. Not true anymore. We've been able to safely do lung transplants on many LAM patients, despite them having bilateral pleurodesis. So it should not be anything against getting a pleurodesis because, oh my gosh, I cannot get a lung transplant. All right, now the whole concept of patients who had pneumothorax and I cannot travel by air, oh my gosh, if I get on a plane, something bad is going to happen. So, and many patients have been avoided, do not travel because your lung cysts are going to rupture. So this was a great study done out in Europe when they looked at 276 patients, 454 flights, and they found that air travel is by and far very well tolerated. And they found that only 4% had pneumothorax, but on investigating those patients, they found that half of these 4 patients had the symptoms of pneumothorax even before they boarded the plane. So in general, air flight is safe. So what would I tell you? I would say that if you don't have any symptoms or you have stable symptoms, we don't discourage our patients to travel by air. But if you get no symptoms, before you travel. Get them investigated before you travel. Second, if you have advanced disease, or you say, you know, I'm somebody, I'm fine, but when I walk, I get short of breath. My husband says I breathe a little stronger and harder. An important thing to do is check to see, even though your symptoms may not be different, check to see, do you need oxygen for that flight? Because most of these planes are compressed 10,000, 15 feet, so the concentration of oxygen up there is a little lower than what we breathe down here at sea level. So if you have oxygen, the work that you are going to do when you breathe up in that airplane is a lot less. And so the likelihood of a pneumothorax is lower. And finally, if you had a pneumothorax, when should you travel? Usually we say that at least for a month after that pneumothorax is healed or has been treated, do not travel. A month after that, by all means, you can go ahead and travel as long as you've got business. Okay, what about the other things? Shortness of breath, chylous effusions. So shortness of breath, like we spoke about a little, is that patients for years are misdiagnosed or incorrectly diagnosed as saying they have asthma, they have emphysema, and doctors can spend hours and say, does your husband smoke? Does your grandfather smoke? Does somebody smoke? Because you got features of emphysema. And when they show you a breathing test, they say, well, this is what normal breathing test is supposed to look like. Yours looks like a toilet seat because it's got that little clip in there. And this is what I mean by the whole concept of the pursed lip breathing, is that in patients with LAM, just like patients with emphysema, air goes in. So this is the air flowing in. They look very similar, but what happens is that it takes time for that air to come out. You fill yourself up with air, but over time, instead of it coming out very quickly, it just slowly fizzes out. And that's why when you get these episodes of sometimes, especially this pain here, pursed lip breathing tends to help with that. And like I said, normal loss of lung function is 15 to 30 ml per year. In LAM patients, it's around 60 to 120 ml per year. Now, remember, this is not universal because we've seen many LAM patients get this, they've been stable, mild for many, many years. All right, so the chylous effusions, this little milky white fluid accumulating in the side of the chest. Now, the curious thing about this is that, like I said, we have way too much lung. So even if you have a little bit of fluid in, in that space, you do not develop any symptoms of shortness of breath. Most patients have to develop a lot of fluid before they develop these symptoms. And we've seen that with chylous effusions, usually we know that the pleura, or the lining of the lung, is very, very heavily innervated. Because we've got a lot of nerves in the chest, the outside of the lungs has a lot of nerves to it. So that's why the pneumothorax, the collapse of the lung, is painful, because of the nerves being irritated. However, when this fluid accumulates in the space between the lung and the chest wall, it is not painful. It's just, you just get short of breath. You're like, gosh, and this dullness in the side of the chest. That's as much as it goes. And most of the time when your physician listens to you, he goes like, oh, I'm not hearing a lot of air in this lower chest, and does the x-ray, and he sees this whole, instead of he doesn't see the diaphragm here, and he sees all this fluid that's over here. So what is usually done? I mean, these effusions occur maybe around, it's not as common as pneumothorax. It's seen in only around 1/3, so only around 30% or so of patients get chylous effusions. And for reasons unclear to us, we've not seen patients who get collapse of their lungs get chylous effusions. We've not seen the two to go together. You get the if you get the chylous effusions, that's what you get. You don't usually get both of them together. And in general over here, now for this, you can either scar the space off so the fluid doesn't accumulate anymore, or if it's mild and occasional, we can drain it out and just watch patients do that. So finally, just a few words on symptoms outside the chest. Because as LAM doctors, most patients who see LAM physicians, these physicians tend to be respiratory pulmonary doctors. So they focus on the lungs, but LAM is a disease that can affect the whole body, but it's a systemic disease, and patients can get symptoms outside the chest. And these are things you should be aware of. And what is the one organ that we always worry about is obviously the kidneys. And we know that these angiomyolipomas or AMLs, even around 50% of patients with sporadic LAM can get these. Most of our TSC LAMs patients have angiomyolipomas. They're usually silent, but when patients develop symptoms, it's either a severe pain in the back, like a kidney stone sort of a pain, or blood in the urine. And usually when either of the two happens, it usually means that this is of significant size. Now these can be prevented, and that's why I talk a little bit about this, because at the end of the day, besides making the diagnosis of LAM, even though these are symptoms that occur, the bottom line for you as a patient and for me as a physician is how can we be proactive in this disease to try and prevent or catch these symptoms early or not even let any of these happen. And that's why I talk about this, because with the whole kidney issue, even if patients with LAM do not have kidney symptoms, we tend to scan or check just to make sure that something is not there. And if as a LAM patient you've not had your kidneys looked into, it's not a bad idea to bring up to your physician, hey, just can we make sure, and you don't need to get a CAT scan, you can just get an ultrasound to look at the kidneys. Go ahead.
Last July, I had my left kidney removed.
Okay.
And how often should my right kidney be looked at?
Okay, I think I have a slide for that. It's usually once a year or depending on the size. So usually what we do is once a year, at least occasionally, we just do an ultrasound of the kidneys, because one thing we're becoming very cognizant of is as physicians we have a lot of tests. We have the ability to do a lot of tests, but we're starting to realize that just because we have a test, is that test safe for the patient over time? And since most of our LAM patients are young, the radiation of CAT scans and things like that can accumulate, and that's something we tend to be sensitive of. And so is ultrasound as good as a test as CT? It is not as good as defining what it is, but it's pretty sensitive enough to pick up if something is there. And so as a screening tool, we just start off with an ultrasound, because you don't have the contrast, you don't have the radiation, it's just a little cold gel at the back. Go ahead.
So, should this be, would this happen at my LAM clinic, or would I talk to my general practitioner?
So, I wouldn't even talk to your general practitioner about it. What I would say is, I would request your LAM or your pulmonary doctor to hook you up to see a urologist or a nephrologist. Usually a urologist is better because they can intervene. Because the reason why urologists tend to be better is that what we do is, if we have patients who have AMLs, even when they're small, and we follow them serially with ultrasounds, if they grow, rather than undergoing surgery like you, sometimes they can embolize it, with interventional radiology. And now, I mean, as they talk to you more and more about rapamycin, we've seen better than the lungs, sirolimus works great for these. These things shrink with sirolimus, it shrinks amazingly. So, I'm almost there. So at the end, I mean, there are a lot of symptoms that LAM patients have, but the bottom line is, because dyspnea can be progressive in LAM patients, make sure you are proactive, you check with your doctor, they check your breathing test to see, is my lung function stable, is my lung function dropping? That's one thing. Should all LAM patients get scanned? Oh, I need a scan every year or every couple of years. And we're starting, even though the recommendations have been every year, every 3 years, all LAM patients need a CT scan of their chest, we're starting to shy back, given more and more data of the accumulative effects of radiation that these patients get. So unless there's change in breathing tests, things like that, we don't tend to routinely scan all our patients. And with the kidneys, we tend to just watch for, with ultrasound, for any symptoms that are, or any concerns related to AMLs. And the last thing I want to say is that rarely patients with LAM can get so-called meningiomas, these growths in the brain. So if you have any headaches, that's another thing to pay attention to. That's another symptom if it comes on. Pay attention to the headache. All right, I think that's about it, and then we'll talk some more.
We have time for a few questions if you want. About 3 or 4 minutes.
I was just going to ask on the headache question, are you thinking of more like a chronic headache or an acute onset of a headache?
Usually, most patients who have, it comes on and then it stays. It's not like a migraine that comes, you shut the blinds, you close the door, you go to sleep, and it goes away. It's a constant, persistent headache that's there.
This is sort of the off-the-wall question, but
Nothing's
since
up there.
this concerns the lymph system, has anybody ever thought about doing manual lymph drainage, and would it help?
Drainage of
The lymph system, you know, where you
massage.
massage and drain the fluid out.
That's actually great. The problem is it's hard to get in over here and massage. But no, I mean, if we had a stocking, like sometimes patients who had issues with their groins or we get a lot of lymph swelling in their legs, if we had stockings we could put around the lungs, that would be great. But no, nobody's been able to drain the fluid out of the lungs. And the reason why the issue with the lymphs in the lungs is so hard is only because almost all the fluid from the entire body drains right into an area right next to where the lungs are. And so that's why it becomes very, very hard to do any manipulation to try and sometimes we have, I mean, in some patients, what we've done is, who have these lymph drainage, we've done lymphangiograms where we inject a little dye into the foot, and then we see this dye creep up through the lymphatics to the body, and occasionally we've seen, oh, there's a rent right over here in the belly or so, where the lymph system is leaking out into the gut, or there's a rent in the middle of the chest, and that's where all the lymph fluid is leaking out, and then we just clip right at that area. So we have done that, and that has solved the problem as well.
I was talking mainly for, I know a couple of practitioners where they just, it's a gentle,
Massage over there.
it's just barely touching it, but it drains it out.
Okay.
I was just wondering, I've never heard anybody say.
Yeah, we've not done anything like that, or I've not seen anything of that regarding to lymph within the chest or belly. Because in LAM patients, it's not like, say, breast cancer survivors who get lymph swelling in the arms, or people who had varicose vein issues with lymph in the legs, or heart failure that get lymph in the legs. It's mainly lymph collection in the belly and lymph collection in the chest. That's the equivalent.
One more.
Okay.
Does that, when you were saying that the lymph can get up in that cause pain too?
Usually not. It just causes a fullness, shortness of breath, things like that. Usually lymph issues aren't painful.
Thank you very much, Dr. Perennial.